My task is to introduce you into the directional atherectomy device technology. I'm involved in this kind of technology since the year 2000, so it's 16 years ago that I did my first Silverhawk atherectomy. At that time it was known as a Fox Hollow system, and we published our own, early experience in 2006, and based on that publication, if we compare the outcome of directional atherectomy with the outcome of the FAST trial, which was a randomized trial comparing the Luminex stent against PTA, you see that in this analysis, directional atherectomy was at least as good as stenting, and by trend it was better, even if this was not a direct comparison. But you can nicely see what you can achieve even in diffuse lesions. Even this is not a long lesion with atherectomy. This was the first generation Silverhawk system, and this was the final result after atherectomy plus post-interventional balloon angioplasty. Well, what more hard data do we have? Definitive LE is a large single-arm study enrolling 800 patients suffering from claudication or critical limb ischemia. You can see the majority of the patients had been claudicants, a minority CLI patients. If you look on the outcome of the claudicant cohort, the primary endpoint was based on duplex ultrasound. It was primary patency. Most of the patients enrolled had been Rutherford category 3. Pre-directional atherectomy balloon angioplasty had to be performed in about 10% of the cases due to the design of the device. It's not a front-cutting device. The nose cone has to be pushed through the lesion before the cutter can be exposed. So concentrically calcified lesions can sometimes not be engaged with the device without pre-dilatation. On the other hand, we had a bailout stent rate of only 3%. So this idea of leaving nothing behind with atherectomy was clearly proven by the definitive LE study. And besides that, there was a consistent clinical improvement over time up to 1 year. You can see here in the upper part of the table, the mean Rutherford category. It was reduced from 3.1 to 1.5 and was persistently increased at 12 months. So what was the baseline lesion characteristics? Mean lesion length 7.5 centimeters, in line with the previous and older stent trials. And this is now the patency outcome based on duplex ultrasound, depending on which threshold for diagnosing restenosis was used, ranging from 78 to 82%. And the interesting finding was that diabetics did perform as well as non-diabetics in this claudicant patient cohort. So what was predictive for primary patency? Well, it was the severity of the stenosis, and it was lesion length, very similar to what we know from PTA and bare metal stenting. Here is the analysis of patency of stenotic and occlusive lesions. You can see that occlusion tends more likely to create restenosis as compared to a stenotic lesion, and the same has been found for longer lesions, longer than 10 centimeters. There you can see a drop in patency, in primary patency at 12 months with a mean lesion length of almost 15 centimeters. But up to 10 centimeters, patency is very similar to what we have learned about, for example, drug-eluting stents and drug-coated balloons. If we look now more closely into the CLI population, the wound healing rate was 72% over time. That clearly shows the need for patency, and that wound healing in Rutherford 5 and 6 patients is a long-lasting event, and short-time vessel patency does not solve the problem of wound healing. Regarding patency, again using the 2.4 velocity ratio threshold, primary patency in the CLI population was 71%. So where we use directional atherectomy in addition, except treatment of atherosclerotic disease in our institution, that's if you want to know whether a lesion of the upper extremity, in particular located at the level of the axillary artery or distal subclavian artery, we start with directional atherectomy, followed nowadays by drug-coated balloon angioplasty. And the idea is to differentiate between an inflammatory disease, a giant cell disease, and atherosclerosis. Here is a very interesting case of a young lady, 24 years of age, with Rutherford 5 CLI presentation. She had developed calf claudication at the age of 13. She was treated by orthopedics for years without any satisfying results. She had no pulses. This was the angiogram of the SFA. She had also some 3-vessel outflow disease. The SFA was treated with directional atherectomy. This was the acute result after atherectomy, and PTA. This was the 3 months result, because the other leg did have exactly the same lesion condition, so she was treated on the left side as well. So we did perform an angiogram of the right leg. You can see something like positive remodeling. This is no positive remodeling, it's simply the relief of the spasm, which was present acutely in this young lady. But what was the interesting aspect of the treatment of this patient, and this was also the background for using atherectomy, was the verification of our suspicion that she was suffering from a atypical giant cell arteritis. So this is a giant cell, what you can see here in the histology. So what can directional atherectomy achieve in calcified lesions? This is the definitive calcium study showing the net lumen gain after atherectomy with TurboHawk is about 2 millimeters as compared to the baseline lumen. And this is very important to know if you consider that calcium is a negative predictor for success for drug-coated balloons. And it's easy to understand the theory behind combining atherectomy and drug-coated balloon angioplasty, that it's very attractive to remove the occlusive material in order to reduce recoil, to improve lumen gain, and secondarily to reduce the diffusion distance of the drug from the inner vessel lumen to the adventitia, where the effector cells, the smooth muscle cells, are located. And these are the devices that had been used in the definitive AR study, which was a 3-arm study more or less. We had a randomized controlled part, and we had a registry arm of severely calcified lesions. This is a short summary of the duplex and angiography-based outcomes. No p-values, because all the differences had not been significant due to the pilot study nature of the study. But overall, there was a slight trend towards better outcome based on duplex and angiography for the combination therapy. Nevertheless, the outcome for the DEB was exceptionally good in the duplex analysis. What we found basically in the subcohort analysis was a trend towards better outcome for the combination therapy in lesions longer than 10 centimeters, and in calcified lesions with a more pronounced difference of the outcome in the angiographic analysis. And what was the lumen gain? Well, lumen gain was very similar in this study as compared to the definitive calcium study. Again, 2.1 millimeter lumen gain by atherectomy, and this might have an impact on the longer term outcome, because what you see here, this is duplex and angiographic derived 1-year patency comparing a residual stenosis of less than 30% as compared to more than 30% after finishing the procedure. So residual lumen does matter. So in conclusion, some DEB and DES offer excellent durability in TASC A and B lesions. However, limitations exist in complex lesion morphology, such as lesions longer than 10 centimeters and severe calcification. And it's worth to explore the combination therapy in the near future. And this will be done by the REALITY study, which is a single-arm study, which will be conducted by the Viva group, and it's planned to enroll more than 250 patients with combining atherectomy with drug-eluting balloon angioplasty. Another nice indication for directional atherectomy are lesions that are involving the common femoral artery, and in particular the bifurcation. This is a case example of treatment of the common femoral artery, the deep femoral artery, and the venous bypass graft originating at the level of the femoral bifurcation, and that's the outcome after atherectomy and additional balloon angioplasty. What we know is that atherectomy in the common femoral artery does perform pretty well. This is the restenosis rate at 1 year, 12%. If we compare that with stenting or PTA, it's even better. So this is how we do it today. This is a diffusely calcified common femoral artery lesion, which was atherectomized, followed by a drug-coated balloon. This is the acute outcome and we are at the advent to start randomized controlled trial comparing atherectomy plus drug-eluting balloon with surgical revascularization of the common femoral artery. Thank you very much.
So I think when talking about calcification and vascular intervention, it's important to first think why we might want to debulk. I'm going to use some of my coronary background to sort of go through reasons why we might want to get rid of calcium in treating arterial circulation. One is that calcium causes dissection. It also prevents appropriate dilatation and stent expansion when stent is elected as the therapy, and also can prevent stent delivery. And it may, in fact, impair drug uptake, and there's been some discussion about this already today. And so this is, again, using a coronary example, but one can see in this optical coherence tomography image of the coronaries that there's different constituent elements of any plaque, and you can see lipid-rich plaque, fibrotic plaque in the lower left, and calcific plaque. And it's the calcium that's really the enemy. By intravascular ultrasound, it appears to be radio bright or echo bright, with a very bright interface at the luminal wall, and with optical coherence tomography, you can see the nodular calcium seen here from approximately 12 to 6 o'clock, about the clock face. So when we are faced with calcium in the vessel, the challenge with endovascular therapies is that calcium is difficult to dilate. And in fact, as you can see in this image from an optical coherence tomography from our core laboratory, that when you apply a balloon angioplasty technique to a calcified lesion, what happens is that the stress is really applied to the opposite wall from where the calcium is. You can see that there's dissection and plaque disruption away from the calcium, which does not yield to the force of the balloon. When you have partial plaque fracture, you still have this kind of dissection, and this can result in other complications requiring stenting. But when you have complete plaque fracture and you can burst through the calcium, you can actually minimize the trauma to the rest of the vessel and effectively expand the vessel. And so I think this is the rationale for lesion preparation, where if you use imaging, as we do in the coronaries, it allows you to identify where calcium is nearly concentric and may be difficult to dilate. And then the modification helps you achieve plaque fracture and expand the vessel. And it would be rare, I think, that plaque modification alone today would be standalone therapy, but it almost always will precede drug-eluting stenting or bioresorbable scaffolds in the coronary and similar techniques in the periphery. So it's really an adjunctive technique to permit vessel expansion. So that brings us to the topic of orbital atherectomy. I think here in the United States, what's available is the CSI Diamondback system, which is 160 centimeter working length and is French sheath compatible. It runs over the Viper wire, which is 335 centimeters with either an 014 or an 014 with an 017 tip, and has 3 different crown morphologies. And the principle of this system is that it uses centrifugal force to, depending upon the rotational speed of the burr, develop a excursion about the midline that varies with the size of the burr and the speed. And it uses the principle of differential sanding in that it will ablate rigid and inelastic tissue while preserving elastic tissue. The advantage of this technique is that you can get 360-degree circumferential contact with the lumen while having ongoing particulate and blood flow through the segment that's being treated. There's been an extensive preclinical and clinical evaluation of this technique through a number of clinical trials, and as was highlighted earlier in Dr. Ansell's lectures, very few of the clinical trials that we see in practice here in the periphery have significant and extensive amounts of calcium, whereas this device is tailored for that kind of application, specifically severe or moderately severe calcification. And there's been over 3,000 patients studied in 5,000 severely calcified lesions. The Calcium 360 study is one of these early experiences with 50 patients that had orbital atherectomy with balloon angioplasty versus balloon angioplasty alone, who were Rutherford 4 through 6. And these were severe calcific lesions, and you can see that the addition of orbital atherectomy both improves has a trend towards freedom from revascularization, and also freedom from adverse events, and importantly, reduces the amount of pressure required to dilate the lesion, sort of corroborating the idea that by plaque modification, one can reduce the rigidity of the lesion. The confirmed series of studies does exactly what it says in both above and below knee disease, demonstrates that in over 200 centers taking all-comer patients with a variety of comorbidities, you can reduce the number of dissections. You can see in each of these studies there's very little in the way of dissection, very little in the way of need for bailout stenting after atherectomy, and a reasonably good safety profile with relatively low rates of embolization and dilation of lesions that would otherwise be quite recalcitrant. And specifically in the CLI patient series, you can see that there's very, very high rates of severe calcification and low rates of complications. So the ongoing Liberty study is a prospective study that evaluates both procedural and long-term clinical and economic outcomes of all endovascular interventions using the adjunct of orbital atherectomy. They're going to seek to enroll 1,200 patients over 5 years, and we'll have independent analysis via the core lab, and specifically with respect to CLI, there will be Rutherford 4 and 5 patients lumped together, as well as Rutherford 6 patients who will be followed prospectively over time. So how does this bear out? Just again, to use a coronary analogy, you can see on the left that the pre-OCT shows concentric calcification, and the post-OCT shows that that calcification is still present, although it may be attenuated. And there's very little luminal gain from the technique itself, but this will render the lesion dilatable. And so here's an example of a clinical patient. This is an SFA that's severely calcified with subtotal occlusion in a Rutherford 4 patient who has significant calcific disease all the way down to the mid to distal SFA. This is so tight, in fact, that it's difficult to actually wire this with an 014 wire, and with some difficulty we're able to get an 014 wire down and then swap out for the Viper wire after we're sure that we're true luminal distally. And with multiple passes of the CSI device, we're able to modify the plaque and alter its compliance enough so that we can balloon dilate it. Even though the residual lumen after CSI is not particularly impressive, we're able to dilate this heavily calcified vessel, and you can see here in the unsubtracted views how much calcium there is in the media, as well as at the intimal level in this vessel. And with both focal force balloons and standard balloons, one can get a respectable angiographic result. Now, it's my practice generally with such heavy calcium to place stents, and in this case I did deliver Supera stents, as was indicated earlier. But I think I would argue that it's difficult to get a very good angiographic result like this in a heavily calcified lesion without doing some degree of debulking a priori, and I think the CSI device is perfectly suited for this in many cases. And you can see that we had an excellent angiographic result as a consequence, and the patient's symptoms were resolved. So I would summarize by saying that for heavy calcification, particularly in patients where you can have true luminal access, the use of orbital atherectomy is extremely helpful, and I think that you'll be seeing more data coming forward in the next couple of years with respect to this application. Thanks very much.
So my talk is to talk about laser for CLI, when, where, why, and how. It's a little bit of a challenging talk because there's not a lot of data. And I'll just start with an 86-year-old guy with claudication that had a bypass because of left popliteal aneurysm. And they used a cryovenous homograft, and 7 months afterwards he had severe claudication with an ABI of 0.466 at rest and high velocities in the distal graft as it anastomosed. You can see here with the trifurcation on the left side there. And there's a little bit of irregularity right at the anastomosis, and this is the angiogram. You look at the right side there, and I will tell you that the wire did not go straight through to that large poststenotic area. It actually had to go down and then back up again. So a very irregular lesion, and of course you can see the TP trunk and the posterior tibial and perineal are severely diseased as well. So we crossed and we decided to lase and then do balloon angioplasty. This is after putting a stent in the TP trunk, but we lased both of these branches and got a very nice result without having to stent that distal anastomotic area after just treating with a balloon alone. And you can see that 7 months later, we came back to treat the SFA because his ABI had still been had been compromised. And you can see his ABI went from 0.66 to 0.92, and at the graft anastomosis, the velocities were much improved from 447 down to 199. And so the question is, why did I use laser in this case? My fellows are always asking me, and there are a couple of them in the audience, why do you choose one thing as opposed to another for a given case? And I'm thinking to myself, well, I probably used it because I felt it would be appropriate to modify the plaque or the fibrous scar tissue that might be associated with significant recoil, to prepare the lesion by debulking such a complex lesion, and maybe avoid having to use a permanent prosthesis in there in a particularly vulnerable location. And also, I think you get a better cosmetic result if you use laser to debulk in advance of balloon angioplasty over balloon alone, and maybe this confers a better long-term patency. Although this is all, subjective and yet to be really confirmed and proven. Laser atherectomy works by modification using photochemical, photothermal, and photomechanical mechanisms of action, and all three of them are influenced by excimer laser. There's a long history of this since the early 90s when I first started doing it with my mentor, Jeff Isner. But in spite of this long history, it's really a paucity of data, especially randomized and controlled type data. So, what I'm giving you is my personal experience and opinions, and I will show you a couple of trials that have been done. So the first that, way back when, to the early 90s, there's a prospective non-randomized trial just using laser-assisted PTA versus balloon alone that reported on 215 symptomatic patients with popliteal occlusions or infrapopliteal occlusions. And the technical success in this series was 99% with very few complications. But these are not very well controlled series. The amputation rate was low, but you can see that the clinical improvement comparing laser to balloon was really not much different between the two categories, whether you were treated with laser or balloon angioplasty alone. Probably the most quoted trial for critical limb ischemia is the Lacey trial, which is run by John Laird and reported out of the Journal of Endovascular Therapy in 2006. And in this trial, a multi-center prospective study in patients with category 4 to 6 who were poor surgical candidates, they were treated with PTA and excimer laser angioplasty of anything along the length of the vessel, infrainguinal, and adjunctive PTA with optional stenting, and the endpoint was limb salvage at 6 months. And they used this series of catheters. You can see that the patients were poor candidates for bypass, this is the type of patients that a lot of them had coronary disease, diabetes, hypertension, and so on. Rutherford category 4 through 6, a lot of them 5 and 6 category, interestingly, and a lot without any good distal vessel to reconnect to, and that's why they were poor surgical candidates. There were 155 limbs treated, 17 deaths, and 6 months follow-up was reached by 127. 9 of them had major amputation, and survival with limb salvage is 93%, which is pretty darn good for this sick a series of patients. This is one of those patients treated in my center with a really nice result. You can see what kind of beautiful result you get from starting out with almost nothing below the knee. And this is that same patient who had healing of the wound. The locations in the Lacey trial were infrapopliteal and SFA in most cases, about balanced, and then some popliteal as well. And you can see that these results have been sort of duplicated with the Belgium trial and the CIS trial. There have been some technical improvements over time with the laser catheters, although the fundamental technology is still the same. They're packing the fibers more closely. They've extended to a turbo and turbo elite and a turbo tandem. You can see there's an eccentric and concentric available catheters, although the eccentric catheter, I think, tends to center itself, so you end up it being not too different from the concentric, although if you apply the turbo tandem approach, where you have a plastic device that sort of pushes you over to one side or another, you can actually get some directionality out of this and get a larger lumen than what you started with, or larger than the catheter itself. So more recently, the EXCITE trial was undertaken to look at in-stent restenosis, because I think this is one area where laser really has a very, very important role. Most of us have felt that if you dilate an in-stent stenosis, the bulk of tissue in there, if you don't debride it or if you don't debulk it with either this atherectomy device or another, then you end up not getting as good a result with balloon angioplasty alone. And Eric Dipple and Craig Walker ran this study. The primary safety endpoint was the first target, major adverse events through 30 days, and the primary efficacy endpoint was freedom from clinically driven TLR at 6 months. And you can see from the efficacy standpoint that laser was indeed superior to balloon angioplasty alone. That's laser plus balloon angioplasty alone. And in terms of freedom from TLR, again, which was an efficacy endpoint, there was a statistically significant difference between laser plus PTA versus PTA alone. Also, primary patency was better. And you can see that for the shorter lesion lengths, 5 centimeters or less, they were pretty much balanced, but the longer lesions, the diffuse in-stent restenosis, clearly was favored by laser as a pretreatment over balloon angioplasty alone. So there are other technologies or other applications for this being explored. There's the European EXCITE data has been reported, and then the combination of using laser with drug-coated balloon. I'm sorry that I don't have any preliminary results of these trials, but these are exciting potential options. I have a conflict of interest in this talk in that I've done some work with a company called Eximo, which is an Israeli company, which has finally at long last developed another type of laser catheter. This happens to be or laser approach. This happens to be a solid state laser as opposed to the gaseous phase laser that Spectranetics has been using for many, many years now, over 25 years. And I think this technology has some advantages over the huge tank that we have to wheel into our room and wait about 20 minutes to warm up. What they're calling this is Blazer, and the reason they call it Blazer is because they associate a metallic blade around the outside of the laser catheter that actually brings to bear both the ablation technique and also a little bit of a gentle cutting technique as well. There's a huge difference between these two catheters in terms of these two systems, in terms of their size, in terms of their ease of use. In that the Eximo system, literally you turn it on and it's activated and can be used right away. So I talked a little bit about the combination of the blade and the laser. The absorption or the wavelength is slightly different as well. It's 355 as opposed to 308, which is where the Spectranetics Excimer is. And there are actually some potential advantages to using that higher wavelength in terms of ablation of calcium and less trauma to normal tissue. So this remains to be shown. There is a preliminary first-in-man study that has been done with 20 cases. Interestingly, 90% of them were CTOs. A lot of them had severe calcium. A quarter of them had severe, and 55% had moderate calcium. And here's just a few of the cases that were done. These were done in Europe over the past 6 months. And you can see that some of them are quite challenging lesion substrates, very heavily calcified in this one, for example. So I think the possible indications for eczema, where you might think of it, where I think of it, are chronic occlusions, where I want to debride the tissue or debulk the tissue. In-stent restenosis, the same. Osteal lesions, like I just showed you of an osteal SFA lesion. Long lesions, occluded vein grafts, moderately calcified stenoses, and previously failed angioplasty. There's been good experience with laser atherectomy over the years. The use is variable from site to site. I would say that the trials need to be better controlled. We need to do more comparative studies, just like everything else that we're doing in the peripheral space. It can also be used for thrombus-containing lesions and in-stent restenosis. And we finally have some new technology that's arriving, which will need to be further studied. We don't know if it's going to be as effective as Spectranetics or not. Just keep in mind, there's laser beams and there's freaking laser beams.
So frontal cutter atherectomy is probably the newest quote-unquote bad boy to these group of devices that are aimed to debulk. The idea here is that these helica blades are going to cut inwards, and that there's a housing within the catheter that actually will take all the debris in. And then there's the concept of the Archimedes screw that tends to cleanse everything. Now, I did have to go back and try to understand what this concept is. It's a very primitive engineering concept, which actually till today still is used pretty much. And it was initially used to actually try to bring water. So you would put this sort of device and then turn the screw, and then the water would just slowly ascend. And that is the principle of this device. You cut up front, and then the screw will try to capture all the debris inside. Now, one of the beauties of it is it comes in 3 different sizes. The first one is a 1.8 millimeter. The second one's a 2.2 that goes through a bigger French, a 6 French. And then the last one to hit the market is actually a 7 French that's deflectable. So it actually gives it some sort of directional properties also. And as you can see, that's a 2.4 that goes over a 7. So actually it increases your range of therapy all the way to the common femoral artery. Now, the catheter itself, it's a pretty simple system. It comes all in one single box. There's no different fluids that you have to add. There's no huge bulky machinery that comes with it. It's pretty much the catheter that can go up to 10,000 to 20,000 RPMs, and then the battery-powered handle that connects immediately, and it has already the batteries inside, so you pretty much flip the on and off. The other 2 things, one is a guide wire clip, which I personally don't use, but it is part of the AFU. And the other one, which I personally don't either use, it's a debris collection bag. As you guys will gain some experience, if you do, you will see that it is actually minimal, the amount of blood loss that you get with this device. Data-wise, we're in diapers. The only thing that's been done at this point is a safety and efficacy at 30 days and 6 months. It was the EASE trial. It was an FDA-approved IDE study that was performed in the US and in Germany. And it was a total of 105 patients with 123 lesions. And the idea was to determine if there was technical success, and that was meant by, could it debulk? Could it clean at least 50% of the initial lumen of that artery? And then certainly the safety at 30 days. If you look at the distribution, they did have those 3 catheters, although when they hit the market, they just released the 1.8 and the 2.2 initially, and now they have done a limited release of the deflectable tip. But they did have both. So there was some above-the-knee lesions, some mesophyseal pops, and some below-the-knee lesions. And certainly if you think that success is based on the debulkment of 50% of the lumen, then you have to adapt the catheter to the lesion that you're treating. So in other words, you wouldn't expect technical success if you just float the 1.8 into a huge 7 millimeter proximal SFA. So if you look at the variables after those 123 lesions, most of them were below the knee, as I said before. So if you see the mean lumen that was treated with 3.52. And short lesions, it was a very limited experience, 34 millimeters plus minus 29. A lot of these patients did have CLI. For it to be a safety and efficacy, it was actually pretty aggressive in that sense because they did allow to enroll up to a Rutherford class 5. The primary endpoint, as I said before, having a debulking efficacy of about 50% or more, was acquired in 95.1% of these patients, with a 5.7% 30-day major adverse event, which were related to non-limb adverse events. If you look at one of the good things that I think this catheter brings to the game is the fact that, number one, it doesn't need any specific distal cage to prevent embolization. As you will see, a lot of the users, and we can certainly have a discussion now when we go through some cases, you will see a lot of us, and I include myself there, in different technologies of atherectomy devices. I will certainly use an embolic protection device. With this device, I have not, and I don't use one. And with the pivotal trial, we had a 1% distal embolization rate. Whereas if you see some of the other trials, certainly can go all the way up to 2.3%. One of the nice things that I'm personally, as I said before, involved is now we're actually trying to put it into real world use. You know, not cherry pick 3 centimeter lesions, but actually go after any sort of lesions. So looking at tibials, diffuse, long, stenotic, and so we're looking at those and including critical limb ischemia patients and following those patients up to 12 months. I will say also that we're doing it all on label. So you're using the 1.8, the 2.2, and the 2.4. And you have to actually abide by the rules that we set in place. So there's a chart of sizing. Like I said, you don't want to be using a 1.8 in a large lesion, in a large artery that's just going to float its way around. Another really cool thing that I think we adapted is I worked with my current boss, Joe Mills, in producing the Wi-Fi classification, which has now been adopted by the Society of Vascular Surgery, which is actually a great way to try to classify most of these patients that we deal with. It looks at the wound status, it looks at the presence of ischemia, and moreover, it also looks at the amount of foot infection, which we think it's crucial. When you look at Rutherford's, although it's easy, it's simple, and it's 6 classes, the reality, going back to the paper from the 80s, is Rutherford said it very clear. Diabetics should not been classified in any way, shape, or form with Rutherford. That was back in the Marlboro days, you know, iliac, aortoiliac disease, not the diabetics. They do not and should not be part of the Rutherford classification. Up till today, and this was actually a week ago, we've already started enrolling 68 patients in this registry, and like I said, we're going to follow this till 1 year, so I'm sure we'll have some interesting data to share with you guys. A couple of cases. Look at that perineal. The first one is just the long occlusion of the perineal. The second one shows you the standalone result after a slow and meticulous atherectomy of that perineal and then balloon angioplasty. This is an SFA lesion. You see that mid portion is out. And one of the nice things also that I've been kind of toying around with, and this is certainly out of the IFU, but is because it's a screw, you could actually float it without a wire into an occlusion. And so we've been using it as a CTO crossing device that actually does debulk a little bit more aggressive than some of the other crossing devices that have been deemed as atherectomy devices too. So this is, as you can see, after you cross, and this is no wire. Let me go back again. You can see there's no wire, and once you get very close to the reconstitution, then you just float this 014 wire down. And you can see this is after just the one pass. This is the 2.2 in an SFA. And after treatment and stenting of the appropriate segments of the SFA, that is the final result. This is another case where we had an in-stent occlusion. You can't really see it, but if you see it, the second image on the right down below, you can see a little bit of the struts. The proximal SFA was still there, and there was large collateral. Again, same deal. A little wire and atherectomy at that, but at the same time, we used it as a crossing system down to where the stent was. Now, as it was getting close to the stent, it started kind of catching on the struts. So at that point, I didn't want to push it. I didn't feel it was safe. And so we opted to do retrograde, get it in the middle, and then we did debulk the ISR slowly, attaining, as you can see in this last image, a complete flow down to the SFA. I will say, however, the Well, that one didn't run. But it is a little on the bulky side when you're using the deflectable tip over an acute angle in the aorta. That video was just to show how it couldn't go through. And, well, there you go. I guess the pitfalls can't be shown, but that was attempting to push Tosaka 3 instant restenoses that actually did embolize a fairly large amount by pushing the catheter fairly quickly. Thank you very much.
So this is one of our patients with critical limb ischemia that presented to our institution. And the patient had Rutherford 5, and you can see that in the distal common femoral leading to the profunda and the SFA, there is a severely calcified lesion that many of us would argue for an endarterectomy, but the patient had multiple comorbidities that led to an endovascular intervention. And as you've seen, all the great speakers that we have here, there are a myriad of devices that can be used. We used one, and this was our result. It was followed by a drug-coated balloon, and no one could argue that it's a very good result, and for that location and the type of patient was excellent. The problem that we have specifically with this technology nowadays is that depending where I go in the country, in the United States, let alone in the world, you could use this device, you could use this device, or perhaps this, or perhaps this. And there's no necessarily rhyme or reason for which one to use, except the fact that the physician may like the rep, or the company for that specific matter, or there's some registry that they are familiar with, or they learn how to do this in their fellowship, or whatever. With the SCAI and other societies, we continue trying to develop this concept, and it's the levels of evidence behind every single decision that we make and every single device in theory that we use. And on the top of this slide is the level 1 evidence, and I guess nowadays we swear by that, and that's how we should be making all our decisions. And when you think about the specific topic that I was asked to comment on, none of the devices, except for perhaps the laser trial for ISR, there are no well-designed prospective multicenter randomized controlled clinical trials that prove the efficacy of these devices. So when Mary asked me, put it all together, then I said, well, do you want me to be sarcastic about it, or do you really want me to say the truth about it? And it's kind of hard to go through that. The truth is that when you look at all the different trials, and this is a slide put in SFA interventions, and you can see all the different devices that we have available, and on the far right of the slide is the atherectomy. All these devices and all these trials are characterized by being small trials. Many of them are non-randomized with multiple endpoints. None of them are necessarily the ones that we choose for critical limb ischemia in some of those trials. The cutoff for restenosis are all over the map. And there are a lot of challenges with our trials. So there are challenges related with the data collection, the endpoints that we use, how do we quantify those, for how long do we think about restenosis, and all this results in lack of consistent and standardized reporting structure, which ultimately may or not affect our decision making. Certainly making randomized controlled trials the resulting level of evidence 1. There are problems related with the type of interventions that we do. Do we put one stent? Do we overlap? If so, for how much? If you contrast this with coronary interventions, we have done such a good job with that. And in the periphery, unfortunately, we haven't. But yet, we use this day in and day out, and the cost associated with it is quite significant. There are other issues related to the patients, specifically if you're talking about critical limb ischemia. So when I think about it, my approach to atherectomy, I basically think about it in 2 different ways. What's the clinical scenario, and what's the type of lesion that I'm going to use? In terms of the clinical scenario, I tend to divide them in both claudication versus critical limb ischemia. Claudication makes me think mostly above the knee, CLI usually below the knee. And then the type of lesion, I think that ISR, there's some randomized data. The comparison of the device versus angioplasty may have not been the best thing to do, but there's some data. And then the de novo lesion. I'm going to choose or go through the rationale for atherectomy. Certainly, calcium is our enemy. It is our enemy in the coronaries. It is our enemy in the peripheral vascular interventions. And I think it's relevant to understand that depending on what we're looking at, 30 to 70% of all the lesions will be calcified. And it has an effect in what we do, whether we like it or not. If you see what is highlighted in the slide, if you look at binary restenosis, those that are more calcified tend to do worse than those that aren't. And that you can start to build a history behind it and justify the use of these devices. A stent fracture, whether you believe it or not, there's definitely an association between a stent fracture and your restenosis rate. And this is a slide showing you that the more calcium you have, and it makes sense, more likely that you will have a higher rate of stent fracture. Lastly, the new kid on the block is the drug-coated balloon, and Dr. Rosenfeld had alluded to this earlier. Certainly, the more calcium you have will impact your results with drug-coated balloon. So we get it. Too much calcium gets in our way. We have to be able to try to deal with it. The problem is, again, we don't have that evidence, and all the evidence that we have is not level 1. I'm going to pick on one of the different devices, no rhyme or reason. I'm just going to use one, perhaps because it's the one that they use the most. So the definitive LE, it was a study done in patients with a specific atherectomy device. It was amazing to me that, okay, so we're trying to deal with calcium, but when you look at the inclusion-exclusion criteria, one of them was severe calcification. So we're trying to answer the question, but we're excluding the patients that are the question we're trying to answer. Maybe a problem. So look in the yellow, we're talking about critical limb ischemia. Okay, so the endpoint is freedom from major unplanned amputation at 12 months. Makes sense, Rutherford 4 or 6. That sounds like a good plan. But then we look at the type of lesions. So for those of us that do critical limb ischemia, show me a patient that has Rutherford 6 with a mean lesion length of 7 centimeters. They don't exist. So it's clearly an issue in the type of trials that we design and in the type of evidence that we're trying to collect. And ultimately, that will affect our decision-making process when we're trying to decide about which device to use. I could use any other device for that matter, and I can go through their data and have the same issues. The one thing that is consistent, though, which is good for us, is that no matter which one we use, the complication rate in the hands of a good operator seems to be very low. So what could I say? Calcium is a problem. I've shown you why. It needs to be dealt with it. I still don't know which one is the best way to deal with them. We lack evidence for the most part, and it seems to be safe. It's unlikely that in the hands of a good operator, you're going to have major complications. This is related to the study. I'm going to quickly browse through that. So finally, I get to answer your question. How do I use atherectomy? Well, I would say that in our institution, certainly is an adjuvant, meaning it's not a standalone intervention, no matter which device we use. I think in our country, the setting in which being used does play a role, whether it's an outpatient lab or an inpatient lab. Certainly physician preference and the impact, unfortunately, of certain companies in how the patterns of usage are will affect that. I do think that the mechanism of action makes a big deal in terms of which device to use. One of the differences is a front-cutting device versus a back-cutting device, specifically for CLI, that may make a difference in terms of your dissection rate and your ability to use, your ability to do extreme lesions below the knee, below the ankle may be affected, and certainly easy to use. Some devices are easier to use than others. Dr. Rosenfeld, for instance, just went through the intricacies of using excimer laser in interventions. It's difficult, it's cumbersome at times, but it's good for certain lesions versus others where you plug and play. So easy to use definitely impact your decision-making process. At the end of the day, I think that what is really lacking is serious data trying to tell us what the real answer is to the question is, okay, it seems like calcium is a problem. Now the next question is, I have all these devices. If I put all these other non-clinical related factors aside, is there any evidence that one of them is superior to the other? And if so, then we can make a decision as to which one should be used, in what kind of patients. It may not be the same one for every single patient, but then we'll be able to make an informed decision. Thank you very much.